And then for those of us who go to developing countries, as I do and some of my colleagues, I can tell you that the access to modern therapies, modern protocols, but also modern therapy and supportive care is much, much less, and outcomes go back to the 1950s and 60s if you really look at them carefully in many of these countries. To me, this is a critical paradigm for what we must do in cancer in general, but certainly in pediatric cancer, and that is in order to make the next jump forward with all of this new technology, molecular technology in particular, we need to adopt this paradigm. Most major centers, major academic centers in pediatric cancer are doing this. And I think as it relates to the patients here, your patients are going to also have the ability to contribute to this, to this data, to help this, because we need to get as many patients looked at as possible because of the relatively small numbers. And that is, we need to have an interaction between the basic research scientist and the clinical research scientist regarding ideas for advancing therapy, ideas at the bench that can be translated into clinical trials. Those ideas are often based on the study of the tissues from the patient, the tumor tissue, the blood, the other biological materials that are obtained primarily as part of the normal diagnostic and treatment approach, not specially obtained necessarily. And those are translated into clinical trials, the results of which then come back through this loop to educate and determine next steps forward. And this loop is incredibly important so that the acquisition of biological materials is critical. And most of the advances we've made in the past 20 years have come from studying these biological materials, human cancers. When I started out in cancer research back in the 70s, everybody was studying animal cancers, animal leukemia, animal solid tumors. That has changed dramatically, and I would say much, much more, if not a majority of the work that's going on in cancer research now is with the human tumor in the test tube, in immunodeficient animal models where you can grow human tumors, etc. But it's gotten away from looking at animal cancers as a model because we know much more from the molecular data we have now that there are significant differences that make the human cancer more important to look at. So this is a very important paradigm. I want to then mention briefly, and this is kind of an introduction to David's talk, I won't spend too much time on this, but the issue of survivorship now becomes very important. We actually have survivors. Again, when many of us started out in the field, we had very, very few. Overall, 1 in 1,000 individuals is a childhood cancer survivor, and between the ages of 20 and 34 in this country, 1 in 570 individuals is a survivor of childhood cancer. That's a significant number. It also makes it important that the primary care physicians begin to learn more about these survivors and what their unique issues are and what they need to do, because these survivors are going to pop up in their offices as patients. There are more and more of them as regular patients. There are over 250,000 childhood cancer survivors in the United States today. So this is not a small number anymore. David's going to talk more about some of the social issues, but I just want to point out that it's very, very important that we feel it's very important that we educate primary care physicians about these problems, because we're talking about kids who, when they grow up, they're very mobile. They're going to travel all over the world, all over the country. They're going to come in contact with new physicians to give them their medical care. Those physicians need to know what to do about these patients, and I think David's going to talk more about that during his talk. But this is an example of why that's important. We know that second malignant neoplasms are one of the most serious complications of cancer treatment. And if you look at, for instance, Hodgkin's disease, which has one of the worst incidence of second malignant neoplasms after therapy, you can see that you're getting up around 20–30% of patients who develop second malignant neoplasms years after their initial treatment for Hodgkin's disease. Much more than some of the other cancers, although certainly leukemias and other cancers do have an increased risk of second malignancies compared to normal people. But look at Hodgkin's disease. Most pediatric cancer centers have had long-term follow-up programs that continue to follow these patients forever, once a year, till they're grandparents. Why is that important? Here's a great example of why. From that kind of data came this information, which showed that after about 20, 25 years, well, actually it's about 15, 20 years after diagnosis and treatment, there began to be an increased incidence of breast cancer in the radiation field of young females who were treated for Hodgkin's disease of the mediastinum. Very common site of occurrence. Standard therapy is radiation plus chemo, right? This is what we get, and it only came about because patients were being followed. Look at this. About a 45% ultimate incidence of breast cancer in the radiation field of adolescent, young adult females with Hodgkin's disease treated with radiation. When this data came out, we immediately looked at it and said, we've got to eliminate radiation for the vast majority of these patients. So we have. We've eliminated radiation for most young adult and adolescent females with Hodgkin's disease who have primary in the mediastinum because of this data. Why? Because the risk of breast cancer and death from breast cancer became greater than the risk of death from not using radiation for the Hodgkin's disease. That's an example of what I was mentioning before about how the risk of death from toxicity can be worse than the risk of death from the cancer in certain selected information and certain selected populations. So this points out to you why it is so important. And again, those of you who are pediatricians, family physicians, etc.,